Welcome, everyone. Thank you all for joining us for this Train the Trainer module on disrupting racism through physician-patient communication and the Presence 5 practices to foster meaningful connection and promote health equity with Black patients. The learning objectives for the Train the Trainer module are: learn the content, background, and communication practices comprising the Presence 5 for Racial Justice curriculum, enhance confidence and skills in leading Presence 5 for Racial Justice curriculum through facilitation notes and frequently asked questions. And lastly, reflect on personal biases and privileges that may impact facilitation of the Presence 5 for Racial Justice curriculum. The formative research of the medical education curriculum began with a literature review through MedEd Portal, Academic Medicine, and PubMed, to identify teaching styles and anti-racism communication practices for medical trainees. We then mapped these strategies onto the Presence 5 framework. We solicited online feedback survey from 37 clinicians and medical trainees involved in diversity, equity, and inclusion efforts across the country. Our team conducted 2 pilot Presence 5 for Racial Justice discussion circles at local and regional conferences and gathered structured feedback from participants. Lastly, we synthesized the feedback from these various sources to revise and finalize the evidence-based curriculum. The Presence 5 for Racial Justice circles are discussion groups to provide medical trainees a safe space to learn and discuss anti-racism communication practices. We recommend that circles are facilitated either by clinician educators, chief residents, or peers. Here is the agenda of a Presence circle, which we will run through in just a moment. First, the facilitator provides an overview of the Presence 5 framework and the Presence 5 for Racial Justice in Medical Education project. Facilitators will then go over the ground rules and discuss norms as a group. Then, facilitators lead participants through a self-reflection exercise and positionality statement to bring participants into a reflective headspace for the discussion. The group will then review each of the Presence 5 for Racial Justice practices and discuss implementation, examples, and barriers to practicing each practice through a case example. Finally, participants will have the opportunity to create specific personal goals and action plans for achieving those goals. For a 1-hour workshop, facilitators should spend 5 minutes providing the overview of the project, 5 minutes discussing ground rules, and 5 minutes on the self-reflection exercise. Facilitators should spend about 35 minutes on the practice discussion, spending about 6 to 7 minutes on each practice. If using breakout groups, plan for 30 minutes of breakout group discussion and 5 minutes to debrief altogether. Facilitators should give participants about 5 minutes at the end to set goals and create action plans, giving space for participants to share their goals with the group. Once the main discussion has come to a close, welcome participants to fill out the feedback survey, allowing about 5 minutes at the end for this activity. At the beginning of the Presence for Racial Justice circle, facilitators will share the following learning objectives for the discussion. Facilitators should say,
by the end of the Presence circle, participants should reflect on anti-Black racism in medicine and evidence-based practices to combat this. Discuss how to apply Presence 5 practices for anti-racism communication through case example, and develop goals to employ at least 1 Presence for Racial Justice practice in the next clinical encounter.
This is the beginning of the overview section, where facilitators describe the Presence 5 framework.
The Stanford Presence 5 framework seeks to foster humanism in medicine by equipping clinicians with the tools to connect meaningfully and build trusting relationships with their patients. Clinicians worldwide have started to use these communication practices to promote humanism in medicine.
Here, facilitators will describe the pivot to racial justice in medical education by first outlining the problem and the solution. You may say,
the COVID-19 pandemic has exposed ongoing racial health inequalities, with Black patients dying from it at twice the rate of white patients. To combat these inequalities, this adaptation of Presence 5 implements strategies to promote anti-racist dialogue among clinicians along with actions to foster better connection and practice with Black patients during virtual visits. The Presence 5 team partnered with clinicians, professionals, and community members to identify anti-racist communication strategies that will improve interactions with Black patients to build trusting relationships. While this is not an all-encompassing guide for anti-racism in medicine, we hope that this will spark discussion, awareness, and accountability for trainees to best serve Black patients. These practices are not a fix-all solution to racism in medicine. Rather, they are evidence-based suggestions that can be employed by trainees to be present for racial justice.
Facilitators will then read aloud the ground rules or ask participants to take turns reading them aloud. Some of the ground rules are:
Be thoughtful in when you choose to speak versus listen. Be considerate of what you are asking of others. There is no pressure to share. And acknowledge each other's unique identity and circumstances. Avoid stereotyping or talking about groups as monolithic, and be mindful of the minority tax. Avoid placing an undue burden of work on minority individuals. Discussion is confidential and judgment-free. Focus on discussing ideas rather than people.
Facilitators should finish this section of the discussion by asking participants to add additional ground rules if desired by speaking aloud or typing them in the chat if virtual. When facilitating a circle, lead participants through a self-reflection exercise. You should say,
to start off this discussion, I'd like to invite you to write a positionality statement. This is a few sentences about your identity, privilege, oppression, position in society, and the perspective you have in this discussion and the perspective you bring to clinical encounters.
Pause the video to take a few minutes to reflect and write your own positionality statement. As a facilitator, think about how your identity may affect the way that you facilitate conversations around race and racism with trainees. Facilitators will now review the evidence-based Presence for Racial Justice practices. The facilitator should paste the link for participant materials, including the PRJ Circle Guide and post-circle mental health resources, into the chat for participant reference if virtual, or share copies of these resources with participants if in person. As you go through each practice, facilitators will begin by stating some of the most compelling evidence we have identified from our formative research, which may also be copied into the chat to give participants another opportunity to read it more clearly. Facilitators will then review the practice description and examples. First, you'll advance the slide and say,
before we dive into each practice in depth, the Presence 5 for racial justice practices are prepare with intention, listen intently and completely, agree on what matters most, connect with your patient's story, and explore emotional cues. To start us off, the first Presence 5 for racial justice practice is prepare with intention. Are you prepared for a meaningful interaction? Our literature review provided evidence suggesting that, firstly, race is a social construct that has been used as a proxy for pathology in medicine, propagating institutionalized racism. Secondly, following a sustained practice of self-reflection regarding implicit biases and engaging in conversations about racism amongst colleagues can begin to reduce bias and racism in clinical settings. The evidence suggests that open conversations between faculty and trainees on power dynamics can empower trainees to address racism in the face of microaggressions. Preparing with intention looks like familiarizing yourself with the person you are about to meet, keeping an open mind about the values and perspectives they may bring to the visit. Consider how your identity and biases could influence the encounter. Specific examples include understanding the influence of racism as a social determinant of health and having a plan and clinic protocol to address bias when you recognize it. The second Presence 5 for racial justice practice is listen intently and completely. What does your patient say when uninterrupted? Evidence suggests that when physicians meet with Black patients, they are significantly more likely to have shorter visits, speak faster, and verbally dominate the conversation. Literature also shows that being aware of your own biases, Considering broad differential diagnoses for every patient and making treatment recommendations based on efficacy instead of convenience can reduce disparities, increase symptom remission, and decreasing chronic impairment. Listening intently and completely involves sitting down, leaning forward, and not interrupting your patient. Position yourself to listen for your patient's experiences with anti-Black racism. Ensure that as you listen, that you hone in on your patient's individual experiences, even beyond healthcare. It is important to respect your patient's comfort level with sharing their experiences and understand that it may take time. Specific examples include positioning yourself to be receptive, taking note how individual and institutional biases have influenced your patient's experiences, and avoiding monolithic assumptions about your patient. The third Presence 5 for racial justice practice is agree on what matters most. How can you and your patient be on the same team? The literature suggests that clinicians have been shown to vary in question asking, diagnostic decision making, symptom management, treatment considerations, referral to specialty care, and interpersonal behavior based on a patient's racial identity. Minority children are more likely to be evaluated and reported for suspected abuse compared to white children and inappropriately referred to Child Protective Services. Black patients report less information giving, partnership building, participatory decision making, and positive talk, and worse outcomes on nonverbal communication, respect, and support. Agreeing on what matters most is about finding out what your patient cares about and being mindful to avoid your own bias about what they should care about. Incorporate your patient's priorities into the visit and develop a plan together that addresses your patient's goals. Specific examples include involving the patient fully in decision making to build trust and prevent stereotyping, as well as considering appropriate referrals to interdisciplinary staff when indicated by the patient's presentation. The fourth Presence 5 for racial justice practice is to connect with the patient's story. How do you combat anti-Black racism in your patient's health journey? Evidence suggests that eliminating language that demonstrates preconceptions about minority racial groups, for example, non-compliant or vulnerable, can lead to improved documentation, history taking, and understanding of patients of color through the context of health disparities and historically discriminatory policies. It is also noted that understanding the history of racism in medicine can help combat anti-Black racism by understanding the historical reasons of lack of trust placed in medicine by Black patients.
Facilitators might also choose to give examples of historical mistreatment, such as the Tuskegee study, Henrietta Lacks, or others, or specific examples of racism in medicine at your institution or geographical region.
Connecting with the patient's story looks like acknowledging social and environmental factors influencing your patient's health and focusing on positive efforts and events. Specific examples include learning about historical instances of racism that may be a part of your patient's story and following your patient's lead when discussing personal experiences with racial trauma. Convey openness to your patient's individual beliefs and celebrate effort and progress using positive language to promote trust and partnership. The fifth and final Presence 5 for racial justice practice is to explore emotional cues. How can you learn from your patient's emotions and support them through experiences with racism? The literature review shows that clinicians block discussion of emotional issues more with Black patients and provide Black patients fewer passive responses that permit emotional talk. Evidence also suggests that clinician attempts to elicit and identify patient emotional cues is associated with greater patient satisfaction, appointment adherence, and learning of conveyed information even when the clinician is mistaken. Exploring emotional cues looks like tuning into racial trauma, noticing and naming your patient's emotions, while following their lead to become a trusted partner. Specific examples include asking the patient to confirm the emotion you see or hear, following up with what you can do to address it. recognizing emotions tied to racial trauma and explicitly name racism, and considering how current events may affect your patient's mental health and feelings of safety.
Now that you have reviewed the evidence and examples for each of the Presence 5 for racial justice practices, facilitators may use the following case example as a starting point for the discussion of the practices.
As we prepare to discuss clinical application of these practices, keep in mind a case for reflection. The case is, you are about to see a new patient. Her chart indicates that she is a 35-year-old Black woman who has hypertension. She has many high blood pressure readings in the chart, and notes suggest that she is non-compliant with her medications and has a complex social history. You prepare to knock on the door to meet her.
As a facilitator, you may read the case aloud or ask a participant to volunteer to read aloud. As you go through the practices, feel free to refer back to the case example to ask participants, what would you do in this situation? Or how would you prepare with intention with this patient if participants do not share personal examples? To ensure enough time and space for all participants to share as much as they feel comfortable, present circles are ideally held in groups of 4 to 10 participants. If greater than 10 participants are present, present the overview and practices as one group and split into breakout groups of 4 to 10 participants for the practice discussion. Each breakout group should be led by at least one facilitator. Optionally, one facilitator may lead the discussion by prompting participants with questions, while another facilitator may voice chat messages, send links or evidence in the chat, and serve as timekeeper. If using breakout groups, plan 30 minutes of discussion around the practices, about 6 minutes per practice, leaving 5 minutes for debrief together with the whole group. Prior to returning to the whole group, facilitators should identify one participant to share a discussion point in the whole group debrief. The host will prompt the groups to return to the whole group at the 30-minute point. Facilitators should display this image or share their screen if virtual at the beginning of the practice discussion to allow participants another opportunity to review the practices. We recommend starting each practice by reminding the group what the practice is about and offering examples. For example, facilitators may then ask,
What do you currently do to listen intently and completely with your Black patients?
as you go through each practice, the facilitator leading the discussion may choose to ask prompting questions at the beginning of each practice or remaining involved throughout the conversation with examples and multiple prompting questions. This is up to you as the facilitator. If virtual, we recommend removing the screen share after the initial practice description in order to feel more connected in the conversation. To begin the discussion around prepare with intention, here are some general conversation starters you may choose to use as the facilitator of the discussion.
What do you do to prepare with intention for your clinical interactions? What practices do you keep on hand to address racism in the moment? How have you navigated power dynamics within the structure of medical education that may influence your ability to provide racially just care? Have there been times where an attending behaves in a way that is racially unjust towards a patient?
If using a case example, you may choose to remind participants that race is a social construct and ask,
How do you take stock of your own identity before you walk into the patient's room?
after allowing some time for participants to share or to start off the conversation, you may offer this suggestion.
One practice to consider is reframe your initial stereotypes, such as non-compliant, with something positive, such as working hard to take care of herself.
To begin the discussion around listen intently and completely, here are some general conversation starters you may choose to use as the facilitator of the discussion.
What do you do to listen intently and completely to your patients in your clinical interactions? How do you listen to your patients with an open mind while acknowledging gaps in clinical training? For example, underrepresentation of Black skin in clinical images. How do you ensure active listening, especially when patients discuss racial trauma?
If using the case example, example, you might explain the importance of knowing the hard data around communication disparities. You may ask participants,
What strategies would you use to allow this patient to tell her story without interrupting? Perhaps this will allow you to learn that she is the caregiver for her elderly parents and kids and often prioritizes their health over hers, which may offer more insight on her unique circumstances.
to begin the discussion around agree on what matters most, here are some general conversation starters you may choose to use.
What do you do to agree on what matters most with your patients? How do you avoid making assumptions about your patient that may affect their healthcare? For example, assumptions around medication compliance, experiences with pain, social issues, role of racism in healthcare. What do you say to reinforce positive health behaviors in your patient and promote empowerment?
If using the case example, you might remind participants to understand the disparities in building trust, asking,
What strategies would you use to partner with your patient to empower her to treat her high blood pressure? You may learn that if she takes her medications when she gives medications to her parents, this motivates her to stay on top of her blood pressure.
to begin the discussion around connect with the patient's story, you may use some of these general conversation starters.
What do you do to connect with the patient's story? Have you reflected on how anti Black racism impacts the health of your patients? What are some examples of racism against your patients that you have witnessed in your clinical education? How has this been addressed? For example, assuming child abuse for a Black child with a fracture. Are there historical examples of racism in medicine from your institution or geographic region that you know of? For example, Henrietta Lacks at Johns Hopkins?
If using the case example, remind participants to appreciate the real role historical racism plays in a patient narrative. You may ask,
How do you respectfully ask about this patient's past experiences with healthcare? With trust, she might tell you that she has felt doctors have experimented on her in the past with different medications.
lastly, to begin the discussion around explore emotional cues, here are some general conversation starters you may choose to use.
What do you do to explore emotional cues with your patient? How do you name emotions that you observe in the moment when it relates to racial trauma? What elements of trauma informed care can you apply when addressing anti Black racism in healthcare? What do you do to promote trust, especially in the context of historical examples in medicine causing distrust in the Black community? For example, Tuskegee syphilis experiment.
If using the case example, you may tell participants to apply trauma-informed care to racial trauma and ask participants,
How do you allow this patient to express her frustrations with her healthcare experiences? She may learn to trust you more as you explore her fears of medication side effects and be open to trying out different treatments.
after the conclusion of the review and discussion of each of the Presence 5 for racial justice practices, facilitators should allow around 5 minutes for participants to develop specific goals for themselves, to incorporate at least one practice into their next clinical encounter. You may ask these questions to prompt their thinking.
What practices do you want to try that you heard today? What barriers and gaps have you identified in your medical education that may perpetuate racial bias? What are you going to specifically do to promote racial justice for your patients in your medical education? What do you need to achieve your goals? What might be challenging, or what are some barriers to achieving your goals?
Facilitators should display this image or screen share if virtual during goal setting to give participants the opportunity to reflect on which practice they intend to implement into their regular care and create concrete steps to complete that action. You may ask for volunteers to share some practices that they hope to implement. Some institutions may want to collect survey feedback on the Presence for Racial Justice Circle for research or quality improvement. If this is the case, as you wrap up the present circle with goal setting, sharing goals as a group, and thank yous, facilitators can share the feedback survey in the chat if virtual, and remind participants to provide their feedback during the last few minutes. Ideally, facilitators should factor in about 5 minutes to allow participants to complete this during the scheduled workshop timeframe. This will conclude the workshop. Now we will go through important facilitation recommendations. Conversations around race and racism can be challenging and may cause discomfort. We will now discuss productive approaches to consider when facilitating Presence for Racial Justice circles. Participants do not have to be the teaching moment. Rely on this guide rather than participants as the teaching tool. Be mindful of the minority tax, which places the burden of work on minority individuals. Do not expect minority trainees to share their experiences and personal anecdotes with racism. Encourage participants to share as much as they feel comfortable. Be comfortable with silence. This may allow for participant reflection, prompting more rich discussion. Acknowledge positionality and privilege, where one stands in relation to society. Evoke cultural humility rather than cultural competence. Try to avoid stereotyping or talking about groups as monolithic, but remember that everyone is evolving. Create a safe space by naming racism during the discussion and fostering trust throughout. Lastly, respect everyone's time and ensure that the circle is completed within the allotted timeframe. While we have run through the structure of a presence circle, if you plan for a 1-hour discussion time, there are several alternatives to using this curriculum that you can implement based on your institution's needs and desires. First, these circles can be conducted virtually through systems like Zoom or in person. If conducting a virtual circle, use the screen share feature to display the slides as needed, and feel free to release the screen share during discussion times to create a more conversational space. If conducting an in-person circle, you may project the slides on a screen or provide individual materials for each participant. The way you structure the presence circle can also vary. You may choose to have a single presence circle where you learn and discuss all the practices in a given time frame, as we have just shown an example of. Alternatively, you may choose to have an introductory circle to learn and initially discuss the practices, followed by a booster circle after a specific time frame to discuss the implementation of the practices and overcoming potential barriers. Another option is to hold a presence circle for each of the 5 practices. With this option, you would have one circle focused on prepare with intention, the next circle focused on listen intently and completely, and so on. Lastly, if you are using breakout groups in a single session, you may decide to have all breakout groups discuss all the practices, as we had shown previously. If you have at least 5 breakout groups, you may choose to assign a practice to each breakout group to discuss and debrief in the main room. As you can see, there are several variations of the presence circle structure that allow you to fit the curriculum to your desired time frame and number of participants. Feel free to modify this as needed. If you decide to conduct a follow-up circle after the introductory circle, you may focus the discussion around the implementation of the practices provided in the first circle and dig deeper into some experiences around race and racism in clinical care. Here are some prompts to use in the discussion of the practices.
How has this been going for you? What have you noticed? Things you already do, things that you pay more attention to now, changes you have made as a result of keeping presence and racial justice in mind? How do you ensure that generalizations are not being made when practicing anti-racism in your clinical interactions with Black patients? What do you do to act as an upstander in the face of anti-Black racism in your clinical interactions and education? What anti-racism practices do you use for in-person versus virtual interactions? How do you stay aware of access to in-person versus virtual clinical encounters? What are the biggest barriers, systemic and individual, to use these anti-racism practices? What do you do to be present when you are witnessing racism in clinical education?
Now we will go through some frequently asked questions to ensure comfort with facilitation and in anticipation of addressing challenges to facilitating these important conversations.
What would you say if the conversation strays to technicalities? For example, specific details around examples of racism, implicit bias testing results, etc.
We suggest redirect to the overall big picture by saying, how have you reflected on racism towards your patients?
What would you say if a participant becomes distressed and or leaves due to the conversation?
We suggest follow up with them one-on-one with open conversation and know when to reach out for help and refer to the mental health resource list provided.
What would you do if there are disagreements around terminology between participants?
We suggest refer to the evidence as a guide, but be open to different opinions. Agree together on what terminology the group is most comfortable with before moving forward.
What would you say if you are asked about your personal experiences with racism in medicine?
We suggest it's up to how comfortable you feel in sharing, but if you choose to share, leave enough space to allow the participants to share more.
What would you do if there is a question about the validity of the evidence?
We suggest refer directly to the evidence in the guide and be prepared to distribute the detailed resources and full articles for participants to access on their own time.
What would you do if there is tension between participant anecdotes and the evidence presented?
Be sure to validate and respect everyone's lived experiences. Be aware that the evidence may not reflect everyone's personal experiences and should be used as a guide.
What would you do if one person is taking up too much time in a discussion group?
We suggest guiding the conversation by prompting with a new question, or if appropriate, suggest other participants to share their reflections. This concludes the Presence 5 for Racial Justice in Medical Education Train the Trainer workshop. Thank you so much for participating and engaging in these important discussions. We would like to acknowledge the large team and generous funding that supported the development of this curriculum. Please do not hesitate to reach us at Stanford Presence 5 at stanford.edu if you have additional questions, comments, or concerns.